Glaucoma is a condition of progressive optic nerve damage which occurs due to increase in the intraocular tension. Now, even though we are seeing increase in intraocular tension, sometimes IOT may be normal. Still, we get some characteristics of optic nerve damage and the changes are classically of that of glaucoma. So, the therapeutic target, even if the intraocular tension is normal, in that case also therapeutic target is to lower intraocular tension. So, what is this intraocular tension? Well, intraocular tension is the pressure in eyeball which keeps the eyeball distended, and this is basically released from the ciliary body. Here it is released and it is filling here. Okay, so it is filling the anterior, or we can say aqueous compartment, aqueous chamber of the eye, and it is keeping the eyeballs distended. However, when this intraocular tension increases, then there is increase in the tension which sclera is able to tolerate, but where the optic nerve leaves the eyeball, there the layers are weak, and that's why there is compression of this area. Now, because of the compression, because the nerves are passing through it, see, within the nerve there is a lot of transport of substances to and fro from the cell body towards the axon and from the axon towards the cell body as well. So, if there is compression of this area, there will be decrease in this axoplasmic transport, and this affects the nutrition of the nerve and ultimately causes the damage to the neuron. And here when we are talking about the optic nerve is basically the axon of the ganglion cells. So it causes the damage to the ganglion cells, and this is irreversible. Now, intraocular tension is a balance between the aqueous humor formation and drainage of aqueous humor. So, on one hand, it is getting formed, that is from the ciliary body, it is released by active secretion, and then it passes through the pupil. So, here it is being released, and then via the pupil, this is iris, via the pupil, it enters into the anterior chamber. So actually this aqueous compartment, it is formed basically by the lens which divides the eye into aqueous compartment and the vitreous compartment, aqueous chamber or vitreous chamber. And again this aqueous chamber is divided by this iris. This is iris into anterior chamber. So this part is anterior chamber, and behind the iris this is the posterior chamber. So by the ciliary body aqueous humor is formed, it is entering into the posterior chamber and then passing from the posterior chamber via the pupil into the anterior chamber, and then it is draining through this trabecular meshwork. So here this is the cornea, okay, and this iris, this is forming an angle, and at the apex, just near the apex of this angle, we have trabecular meshwork, and the aqueous humor which is formed drains via this trabecular meshwork into the canal of Schlemm and then into the episcleral veins. So let us see a little bit in detail how this aqueous humor is formed and how it is drained, and that will help us in understanding the mechanism of action of various drugs. So first is formation of aqueous humor. So aqueous humor is formed by the ciliary body, and actually this ciliary body, that is a non-pigmented epithelium. So this side is the posterior chamber. If we see, this is the non-pigmented epithelium, this diagram we are talking, and here it is posterior chamber. And here a very unique arrangement of cells is there, that is there is pigmented epithelial cell which is contact with the non-pigmented epithelial cell by gap junction. So here there are gap junctions. Okay, so we see certain transporters. This is the blood vessel. Okay, so this is the ciliary epithelium, this is the blood vessel. So here blood vessel is somewhere here, this is the blood vessel. Okay, now this basolateral membrane of the pigmented epithelium has the sodium potassium 2 chloride transporter, which is symport, and via this potassium, sodium and chloride enter into the cells, and then this sodium goes out and again potassium enters into the cell by this sodium potassium ATPase. Okay. So because sodium enters into the posterior chamber, chloride also follows, because this is the positive ion. To neutralize it, chloride also follows into the posterior chamber. Now, in this non-pigmented epithelium, we also have an enzyme carbonic anhydrase. And as we know from our basic fundamental physiology, that carbon dioxide reacts with water in presence of this carbonic anhydrase enzyme and forms H2CO3, which dissociates into hydrogen ions and bicarbonate ions. So now this bicarbonate ion actually enters into the posterior chamber and there is recycling of this chloride. Now remember that this recycling of chloride can only happen if there is permeability of this chloride channel, and this is affected by CAMP. Okay, more the CAMP, more the permeability, and hence more chloride channel will go, and hence more bicarbonate ion will enter into the cell, and this increases the tonicity in the posterior chamber. Thus, water follows passively from this side to the posterior chamber. So, there is a passive movement of water by osmosis. Okay. So, three things to remember here. One, that chloride permeability is important and it is dependent on CAMP. Second, carbonic anhydrase enzyme is important, leading to the formation of bicarbonate, which is ultimately entering into the posterior chamber. And third, that water is entering by osmosis due to the change in the tonicity. More the tonicity in the posterior chamber, more water is going to enter into the posterior chamber. So we will see later that how pharmacological agents act via these mechanisms. Now, you see here in the ciliary epithelium, we have certain receptors, that is alpha 2 and beta 2 receptors. So, we have drugs which will act on these receptors, and also on the blood vessels we have receptors, that is alpha 1 and beta 2 receptor. And like majority of the blood vessels, stimulation of the alpha receptor leads to vasoconstriction, and stimulation of this beta 2 receptor, it leads to vasodilation, right? Fine. So that was about the formation of the aqueous humor. Moving on to drainage of the aqueous humor. So ciliary body is forming the aqueous humor which is entering into the posterior chamber. Then via the pupil, via here, the aqueous humor is entering into the anterior chamber, and from there the aqueous humor is draining through the trabecular meshwork. So 90% of drainage is through this trabecular meshwork, then into the canal of Schlemm, and finally entering into the episcleral veins. But 10% of this drainage is also via uveoscleral outflow. What is that? You see here, this is the ciliary body, and here at the base, this iris is attached, but some portion of ciliary body is here also. So, some of the aqueous humor passes through this ciliary body and goes via the connective tissue into the ciliary body to the episcleral vein. So, that is known as uveoscleral outflow, and that is responsible for 10% of aqueous humor drainage. So, now moving on to the causes of glaucoma. Glaucoma, that is, as I told before, increased intraocular tension can occur due to increase in formation of aqueous humor, decrease in drainage of aqueous humor, and increase in the pressure in the episcleral veins, which in turn will decrease the drainage of the aqueous humor, because we saw from trabecular meshwork to the canal of Schlemm to the episcleral veins. So if the pressure in episcleral veins is more, it is impede the flow of the aqueous humor into the veins. So since intraocular tension is a balance between the production and drainage, we are seeing that either increased production or decreased drainage, it is going to increase the intraocular tension. Now amongst these causes, these two are rare. It is mainly decrease in the drainage which causes the glaucoma. So primarily we have two types of glaucoma, that is primary open angle glaucoma and primary closed angle glaucoma, but we can also have secondary causes of glaucoma. But in that also what happens, that some exudates block this trabecular meshwork here, and then that will cause a decrease in the drainage of the aqueous humor. So in primary open angle glaucoma, the cause is not caused by some other disease, but there is decrease in patency of trabecular meshwork, and this can lead to increase in the intraocular tension, and when it becomes more than 21 millimeter mercury, we call it as increased IOT. But remember that the IOT can be normal as well. However, we will target to decrease intraocular tension if we get the characteristic changes of glaucoma. Then closed angle glaucoma or narrow angle glaucoma or acute congestive glaucoma, what happens that the iris attaches to the lens like this. Okay, when there is mydriasis, that is dilation of the pupil. So this causes attachment of the iris to the lens in susceptible eyes only. Now, because of this, there is decrease in the movement of the aqueous humor via the pupil to the anterior chamber. This doesn't happen, and the aqueous formed starts accumulating here. This pushes the peripheral end of the iris towards the angle, and this mechanically actually blocks the anterior chamber. So that is why this is known as closed angle, because this angle becomes more acute like this. So the iris pushes on this angle and closes it. So that is why it is known as closed angle or narrow angle glaucoma. So what are the therapeutic targets? So in primary open angle glaucoma, we have 5 different therapeutic strategies. These include beta blockers, alpha agonists, prostaglandin analogs, carbonic anhydrase inhibitors and miotics, and they will be targeting either the production or the drainage. We will see each of them one by one. So first one is beta blockers. So how will the beta blockers act? Well, we have seen before that the blood vessel as well as the ciliary epithelium has beta receptors. We'll go back to the diagram. So this is what we saw. So what happens that when we block this beta receptors in the vessel, there will be vasoconstriction, because what is the function of beta receptor stimulation? It will cause vasodilation, and we are blocking the beta receptor. So this would lead to vasoconstriction, and if this blood vessel becomes constricted, then there will be less movement of the ions, less movement of the water to the cells and hence into the posterior chamber. So that is one. Second thing is that because I told you that CAMP, the concentration of CAMP is important for this chloride channel permeability. When CAMP is more, chloride channel permeability is more, chloride moves there more. Now, when beta receptors, which are of beta 2 type, they are blocked by this beta blockers, this CAMP decreases, and this leads to decreased chloride secretion and hence decreased aqueous humor formation. So, this beta blockers acts by 2 mechanisms. One, by decreasing the blood flow, and second, by decreasing the permeability of the chloride channel because of decreased CMP. But overall, basically, they are decreasing the secretion of the aqueous humor. So, beta blockers, how do they act? They decrease the secretion of the aqueous humor. So, in this, basically the drugs which we want should be lipophilic because it is given topically. Okay, so it should cross that cornea barrier and enter into the eye. And it should not have local anesthetic action, because eye actually we should not keep it anesthetized. It can be dangerous. It can lead to ulcer in the cornea. Then it should not have any intrinsic sympathomimetic activity. So the drugs which can be used are timolol and betaxolol. Timolol is a non-selective beta blocker, so it will block beta 1 as well as beta 2 receptors. Now, certain advantages and disadvantages are there for timolol. One, it is very effective drug. It can cause up to 25% reduction in intraocular tension. Second, if used chronically, then even after discontinuation, effect lasts for 1 to 2 weeks. So suppose if the person forgets to take the eye drops for 1 or 2 times, that does not affect the efficacy of the drug. It is still able to act. But there can be certain side effects. Local side effects, they are less, but sometimes there can be development of inflammation, that is blepharoconjunctivitis can occur. But if it is absorbed into systemic circulation, in that case, it will have effects just like any other beta blockers. So beta blockers are contraindicated in patients of asthma, bradycardia and AV block. And even when applying timolol, we should tell the patient, we should educate the patient to close this part of the eye for 5 minutes. Just compress there for 5 minutes after applying the drop, so that the drug is not absorbed into the systemic circulation. Second thing is that in asthmatic patients, we can actually start with betaxolol, which is beta 1 selective. But we have seen that the receptors which are present in the eye are of beta 2 type. Mostly they are of beta 2 type. So when you give beta 1 selective, obviously it will be not that effective. So in case betaxolol is not giving the response, then we can later on switch to timolol. So that was the beta blockers. Next is the adrenergic agonist. In adrenergic agonist, we have different types of drugs. One, the non-selective one, which can act on alpha 1, alpha 2 and beta 2 receptors. Then we have the selective one which act on alpha receptors only. We have apraclonidine which acts on both alpha receptors, that is alpha 1 and alpha 2. Then we have brimonidine which acts only on alpha 2. So dipivefrin is an analog of adrenaline. Within the eye, it is broken down by esterases to adrenaline, and it acts by acting on all three types of receptors, alpha 1, alpha 2 and beta 2. So how it acts? Basically by acting on alpha 1 and alpha 2 receptors. Remember, this is agonist. Okay. So if it acts on alpha 1 receptors, it will cause vasoconstriction. We have seen alpha 1 receptors are present in the blood vessel. It is going to cause vasoconstriction. So it is going to decrease the aqueous humor formation. Alpha 2 receptors, when it acts, it actually, this is an agonist. So this is going to decrease CMP. Yes. Beta blockers decrease CMP. Actually, what happens? The beta receptors are associated with G protein coupled receptors, which are of GS type, and this ultimately leads to stimulation of adenyl cyclase enzyme and increased CMP. So when we block the beta receptors, the CMP decreases. On the other hand, these alpha 2 receptors which are present on the ciliary epithelium, they are associated with G protein coupled receptors which are of GI type, inhibitory type. So they cause decreased stimulation of adenyl cyclase and hence they cause decrease in CMP. So alpha 2 agonist will decrease CMP, decrease the permeability of chloride channel and hence decrease secretion. On the other hand, this beta 2 receptors, they are also present on the trabecular meshwork. So if there is beta 2 agonist, this is agonist action. We have seen beta 2 blocker. This is agonist action. Some amount of increase in permeability can occur because of increased permeability of the trabecular meshwork, and hence there is increase in trabecular outflow. Okay, so if we see these three drugs, it will be dipivefrin which will act by all these mechanisms. Apraclonidine will cause decrease in formation because it is affecting alpha 1 and alpha 2. Brimonidine will act only by affecting this alpha 2. Okay. Now, these drugs are used only either for short-term control or for add-on therapy. Dipivefrin can be used as an add-on therapy. For example, if we are using one particular family of drugs, say beta blocker, if the intraocular tension is not being controlled, then dipivefrin can be added as an add-on therapy. On the other hand, apraclonidine and brimonidine, they are used for short-term intraocular tension control before and after surgery, before and after laser trabeculoplasty or iridotomy. Okay. Side effects of this drug, because they are alpha agonists, they include vasoconstriction, vasodilation, rebound phenomena, and this can lead to red eye. Okay. Apraclonidine side effect is lid retraction can occur. One mnemonic for this is apraclonidine. So I put it as opera. So lid becomes opera, lid becomes up. Okay. So apraclonidine, lid retraction. Brimonidine, one side effect is CNS depression. Then next family of drug is prostaglandin analogs, and in fact this prostaglandin analog has become the drug of choice for primary open-angle glaucoma. Why? First, it is longer acting. It can be used only once daily. When we were talking about timolol, the beta blocker, it is used BD, but prostaglandin analogs can be used only OD. Second, efficacy, it is similar to timolol. That means it can cause reduction of 25 to 30% intraocular tension, and there are no systemic side effects unlike timolol. So instead of going with timolol for asthmatic patient, directly go with prostaglandin analogs. Okay, and they act by increasing the uveoscleral outflow. So we have seen before that some of the aqueous humor drains via the ciliary body connective tissue. So that is uveoscleral outflow, responsible for 10% of normal aqueous humor drainage. Prostaglandin analogs increase this uveoscleral outflow. Some of the drugs in this class include latanoprost, travoprost, bimatoprost, uniproston, and the side effects which can occur with this prostaglandins analog include macular edema. Macular edema. Water can accumulate in the macular region, especially in patients without lens. It can lead to increased iris pigmentation. It can cause thick and dark eyelashes, and it can also cause blurring of vision because of macular edema. So what are the side effects? As a mnemonic we can remember, because these are prostaglandin or PGF2 alpha analog. So just write PGF, P for pigmentation of the iris, G is growth of the lashes, and F is fluid in macula. Then moving on to the next class of drug, that is carbonic anhydrase inhibitors. So we have seen this diagram before. So if simply this carbonic anhydrase is blocked, then there will be less secretion of bicarbonate ion into the posterior chamber, and hence there will be less movement of water into the posterior chamber. So that is the mechanism of action of carbonic anhydrase inhibitor. But remember, because of so many side effects, it is rarely used. In fact, acetazolamide, which is a drug which is used orally, it is the last resort if intraocular tension is not controlled, or it is used IV in case of angle closure glaucoma that we are going to see shortly. It is also used before and after ocular surgery. Since acetazolamide is an oral drug and it can lead to many side effects, so one of the very important ones being acidosis, topical carbonic anhydrase inhibitors have been developed, that is dorzolamide and brinzolamide, and again these can be used as add-on drugs or when other drugs are contraindicated. So again, if the intraocular tension is not being controlled by the other drugs, then these drugs can be added. Basically, for each patient we have certain target intraocular pressure. Okay, so we have to define the target intraocular pressure individually for each patient depending on the changes which have occurred in the optic nerve, and that target intraocular pressure, if it is not being achieved by a particular drug, then add-on drugs can be added. Moving on to the last class of drugs, that is the miotics. These miotics basically are parasympathomimetics. So they cause the ciliary muscle contraction also and sphincter pupillae contraction also. Contraction of the ciliary muscle is responsible for the accommodation of the lens. But when the ciliary muscle contracts, there is increased patency of trabecular meshwork. Some structural arrangement takes place there, which leads to increased patency of trabecular meshwork. However, because of persistent ciliary muscle and sphincter pupillae contraction, it can lead to headache. So that is the side effect, and miotics are not used for long duration because there is certain side effects attached to it, like with pilocarpine, which is short acting miotic. It can lead to fluctuations in intraocular pressure. Okay, so you have to give repeatedly, and it is short acting, plus it can lead to, because of the short action, it can lead to fluctuations in intraocular pressure. It can also cause punctal stenosis of the nasolacrimal duct. Then another parasympathomimetic which was tried but is not used now is ecothiopate. It can accelerate cataract development. So this pilocarpine is directly acting parasympathomimetic. I've already dealt the parasympathomimetics in another video. Do watch that to understand this ANS pharmacology. Then, because it will lead to sphincter pupillary contraction, there will be decrease in pupil size, decreased light entry into the eye, and hence there will be decreased vision. So again, miotics are not used regularly for primary open angle glaucoma. Moving on to angle closure glaucoma. As we have seen the pathophysiology before, what happens in angle closure glaucoma? That with mydriasis in a susceptible eye, this iris is going to make contact with the lens. Then aqueous humor will not be able to move via the pupil into the anterior chamber. It will accumulate here in the posterior chamber and push this part of iris anteriorly, thus making this angle narrow and decreasing the aqueous outflow. So what to do in this case? Well, this case is like an acute attack of increase in intraocular tension. So we have to decrease the intraocular tension fast. And we have seen in the routes of administration that when it is an emergency condition, we go for IV drugs. So what are the IV drugs we will use? The initial drug of choice in this case is acetazolamide, the carbonic anhydrase inhibitor, and it is given IV. Even hypertonic mannitol 20% can be given IV. Then second thing is we want to pull iris away from angle, and for this miotic is given. So I told you that dilation of the pupil cause the iris to attach to the lens. So in this case we will cause the constriction of the pupil. So that is occurring by miotic. See, before we have seen in the primary open angle glaucoma that miotic is basically acting by increasing the ciliary muscle tone and hence increasing the patency of the trabecular meshwork. But here we are saying differently. Here we are saying that the main action here is the miotic action, that is the sphincter pupillary contraction, which will pull iris away from angle, and that is going to allow the passage of the aqueous humor from the posterior chamber into the anterior chamber. So in this case, pilocarpine is used every 10 minutes. 1 to 4% of pilocarpine is used every 10 minutes. Then further to decrease intraocular tension, we can add timolol, epaclonidine, latanoprost. Depending on the response, we can add single or multiple drugs. And once this intraocular tension is controlled, we have to do laser iridotomy. So first thing is to control the acute attack. So by doing this, okay, all these three, we are controlling the acute attack. I didn't tell you the mechanism of action of hypertonic mannitol. Actually, we have seen before that how water is moving by osmosis from one side to the other side, because here in posterior chamber there is increased tonicity. So what we are doing, that by increasing the tonicity in the blood, we are giving IV mannitol. So that is going to increase the tonicity in the blood. So this will prevent the water movement from this compartment to the posterior chamber, right? So that is just increasing the blood tonicity. Yeah, so I was telling that after decreasing the intraocular tension by these various mechanisms, once intraocular tension is controlled, laser iridotomy needs to be performed. That is making a hole in the iris, so that even if there is touching of the iris on the lens, there is not complete blockage of the pathway, and via that hole, the aqueous humor will enter into the anterior chamber. Okay. And it has to be performed in both the eyes, not in one eye. So even if the attack was there only in one eye, prophylactically the surgery has to be performed in both the eyes, because it is very dangerous. Since intraocular tension, if it increases, it can increase to very high levels and can damage the optic nerve, and this damage is permanent. It is not reversible. So that was about the drugs which are used in glaucoma. As always, the video notes for this video will be available for free download from the app. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.